Measles. Introduction. Measles is an acute, highly infectious disease of childhood caused by RNA paramyxovirus. It is clinically characterized by fever and catarrhal symptoms of the upper respiratory tract followed by typical rash. Measles occurs only in humans. Epidemiology. Agent factor. A. Agent, RNA paramyxovirus. B. Source of infection. The only source of infection is case of measles. C. Infective material. C. Creation of the nose, throat, respiratory tract during prodromal period and early stage of rash. D. Communicability, for days before and 4 days after appearance of the rash. E. A secondary attack, infection confirm the lifelong immunity. Host factor. A. Age, occurs at any age but mostly affect childhood between 6 months to 3 years, in developing countries up to 5 years. B. Sex, incidence equal. C. Immunity, one attack of measles confirm lifelong immunity, secondary attack rare. D. Nutrition, measles very severe in malnourished child, mortality 400 times higher than well-nourished child having measles. Environmental factor. Give a chance, virus can spread in any season. In temperate climates, measles is a winter disease, probably due to people crowd together in indoors. Epidemics of measles are common in India during winter and early spring. Transmission. Transmission occurs directly person to person by droplets infection and droplets nuclei. From 4 days before and for days after appearance of rash. The route of entry is respiratory tract. Infection through conjunctiva also considered. Incubation period. Onset of fever after 10 days from exposure and 14 days to appearance of rash. Clinical features. There is 3 stages. 1. Prodromal stage. 2. Eruptive phase. 3. Post-measles stage. 1. Prodromal stage. It starts 10 days after infection and lasts until day 14. It is characterized by fever, coryza with sneezing, cough, nasal discharge, redness of eyes, lacrimation and often photophobia, vomiting or diarrhea. Koplik spots. 1 or 2 days before appearance of rash, Koplik spots appear on buccal mucosa opposite the first and second lower molar. They are small, bluish-white spots on a red base, smaller than pin of head. 2. Eruptive phase. This is characterized by a typical, dusky red, macular or maculopapular rash which starts behind the ear and spreads rapidly over the face and neck. Extends down the body taking 2 to 3 days to progress to lower extremities. The rash may remain discrete, but often it becomes confluent and blotchy. In the absence of complications, the lesion and fever disappear in another 3 to 4 days. It is the sign of end of disease. The rash leaving a brownish discoloration which may persist for 2 or more than 2 months. 3. Post-measles stage. White loss and weakness for number of days. There may be failure to recover and gradual deterioration into chronic illness. There may be growth retardation and diarrhea. Cancromoris. Pyogenic infection. Candidosis. Reactivation of pulmonary tuberculosis, etc. Complication. The severity of measles depends upon host and environmental factors. Common complications of measles. Pneumonia. Diarrhea. Otitis media. Post-infectious measles encephalitis. Subacute sclerosing panencephalitis, SSPE. In developed countries, death due to measles is rare as 0.01 to 0.1%. In developing countries, case fatality rate for measles, 3 to 6%. Greatest risk of death is in children younger than 1 year and in adult older than 30 years. In HIV-infected child, case fatality rate has been reported to be as high as 50%. Treatment. Supportive treatment should be provided, including relieving common symptoms such as fever, cough, nasal congestion, conjunctivitis, and sore mouth. Give the nutritional support to prevent the malnutrition. Oral rehydration salt should be used to prevent dehydration. Breastfeeding encouraged where appropriate. Isolation to prevent spread of virus. In severe measles and all cases of measles in area with high mortality rate should be treated with vitamin A. Vitamin A deficiency lead to keratomalacia and blindness. A high dose of vitamin A is given immediately on diagnosis and repeated the next day, and third dose given if needed. Recommended dose of vitamin A: 50,000 IU for infants aged less than 6 months. 1 lakh IU for infants aged 6 to 11 months. 2 lakh IU for children aged 12 or more than 12 months. Prevention of measles. 1. Measles vaccinations. Vaccine. Live attenuated vaccine are recommended for use. Vaccine presented as freeze-dried product. Before use, the vaccine is reconstituted with sterile diluent. Diluent cooled before the use. Measles vaccine may also contain sorbitol and hydrolysed gelatin as stabilizer, as well as small amount of neomycin. The vaccine is sensitive to sunlight, hence it is kept in colored glass vials. After reconstitution, the vaccine must be stowed in the dark at 2 to 8 degrees Celsius and used within 4 hours. Vaccine is available in monovalent form and in combination, MR, MMR, MMRV. Administration, subcutaneously, on right upper arm. Dose, 0.5 ml, 2 doses. First dose, 9 completed month to 12 month. Second dose, should be given between 15 to 18 months. Interval between first and second dose, minimum 4 week. Vaccine is not recommended for HIV-infected person. Immunity develop 11 to 12 days after vaccination, and vaccine provide lifelong immunity. Vaccine induce a mild measles illness 5 to 10 days after immunization in 15 to 20% of vaccinees. Toxic shock syndrome produce when vaccine is contaminated or same vial is used for more than one session on the same day or next day. 2. Immunoglobulin. Measles may be prevented by administration of immunoglobulin early in the incubation period. Dose, 0.25 ml per kilogram of body weight. It should be given in 3 to 4 days of exposure. Thanks for watching. Like and subscribe for more.